Molecular classification of colorectal cancer, understanding the pathways, subtypes, and therapeutic implications. Welcome to today's deep dive into the molecular classification of colorectal cancer, a journey that has taken us from viewing this disease as a singular entity to recognizing its remarkable complexity. This evolution in our understanding is not merely academic, it has laid the foundation for transformative changes in how we approach prognosis and treatment, especially in the age of targeted therapies and immunotherapies. Let us begin by exploring the fundamental pathways through which colon cancers arise. There are three principal routes, each characterized by its own molecular signatures and clinical implications. The first and most common pathway is known as chromosomal instability. Here, cancer emerges through a sequence of genetic events involving key genes like adenomatous polyposis coli, Kirsten-Ratt sarcoma viral oncogene homolog, and tumor protein page 53. These genetic mutations result in chromosomal abnormalities, ultimately leading to the development of gland-forming adenocarcinomas. The prognosis in this group can vary widely, depending on the specific stage and the ensemble of mutations present. The second pathway involves microsatellite instability, or what is termed mismatch repair deficiency. In this scenario, the system responsible for correcting errors during DNA replication is defective, resulting in a cascade of mutations. The most frequently affected genes in this pathway include MUTL homolog 1, MUTS homolog 2, MUTS homolog 6, and PMS1 homolog 2, either through inherited mutations or by silencing via promoter hypermethylation. Tumors that arise through this route often display poor differentiation, mucinous features, and a pronounced lymphocytic infiltrate, which can be seen under the microscope. Interestingly, when compared stage for stage, these tumors tend to offer a better prognosis, though this can be significantly influenced by modern therapies. The third major pathway is the CpG island methylator phenotype, sometimes referred to as the serrated pathway. Here, widespread silencing of tumor suppressor genes occurs due to promoter hypermethylation. A hallmark mutation in this route is found in the BRAF proto-oncogene, especially in cancers located on the right side of the colon. The precursor lesions are typically sessile serrated adenomas or polyps, and the histology often reveals serrated architecture and mucinous features. Unfortunately, this pathway is associated with poorer survival, especially for those with advanced disease. As our understanding deepened, researchers developed a more integrated view known as the consensus molecular subtypes. This framework draws on gene expression profiles to classify colon cancers into four main subtypes, each with unique characteristics and clinical behavior. The first subtype, called the microsatellite instability immune group, is defined by hypermutation and strong immune activation. These tumors are notable for the frequent presence of BRAF mutations and tend to have a favorable prognosis in early stages, though they may recur later in isolated locations. The second group, the canonical subtype, is driven by chromosomal instability and shows activation of epithelial differentiation and specific signaling pathways. These cancers carry an intermediate prognosis. The third, the metabolic subtype, is characterized by disturbances in cellular metabolism and a mixture of microsatellite stability and instability. Kirsten-Ratt sarcoma mutations are common in this group, which also shares an intermediate outcome. The fourth group, the mesenchymal subtype, involves activation of transforming growth factor beta, increased invasion into surrounding tissues, new blood vessel formation, and a process known as epithelial mesenchymal transition. This group tends to have the worst prognosis, with a high risk of recurrence and distant spread. It is important to note that a small percentage of tumors defy classification or present with mixed features. From a practical standpoint, the most crucial aspect of molecular classification is its value in guiding treatment decisions, especially for patients with metastatic disease. There are several biomarkers that clinicians routinely test for, and understanding their significance is key. First is the status of microsatellite instability and mismatch repair deficiency. Tumors with this profile are highly responsive to immune checkpoint inhibitors such as pembrolizumab and nivolumab. These therapies have been approved for use regardless of tumor site and represent a distinct, highly responsive population. Second, amplification of human epidermal growth factor receptor 2 is detected in a small percentage of metastatic cases. Tumors with this alteration may be treated with targeted agents like trastuzumab and pertuzumab, or trastuzumab deruxtecan. This amplification is also a mechanism of resistance to anti-epidermal growth factor receptor therapy and is more common in left-sided colon cancers. Third, the BRAF V600E mutation is found in roughly 8 to 10% of cases, and it confers a very poor prognosis when standard chemotherapy is used. Therefore, it requires a specialized combination of targeted therapies, such as encorafenib and cetuximab, sometimes with binimetinib. Fourth, mutations in Kirstenrat sarcoma and neuroblastoma RAS viral oncogene homolog are found in half of metastatic cases for the former and about 5% for the latter. These mutations predict resistance to anti-epidermal growth factor receptor therapies, making it essential to confirm wild-type status before considering such treatments. Fifth, fusions involving neurotrophic tropomyosin receptor kinase genes are exceedingly rare but highly actionable. Patients with these fusions can experience dramatic responses to therapies like larotrectinib and entrectinib. Lastly, the location of the tumor within the colon, whether proximal or distal, matters greatly. Tumors on the left side generally have better outcomes and are more responsive to anti-epidermal growth factor receptor therapy. Right-sided tumors, on the other hand, are often associated with BRAF mutations, microsatellite instability, and the CpG island methylator phenotype, and may benefit more from therapies like bevacizumab. To summarize, for all patients with metastatic colorectal cancer, mandatory molecular testing should include assessment of mismatch repair and microsatellite instability, Kirstenrat sarcoma and neuroblastoma RAS status, and BRAF status. Further testing for human epidermal growth factor receptor 2 amplification and consideration of anti-epidermal growth factor receptor therapy becomes relevant if the tumor is wild-type for RAS and BRAF and displays microsatellite stability. If the tumor is mutant for BRAF, targeted combination therapy is necessary. If there is microsatellite instability or mismatch repair deficiency, immunotherapy is the preferred approach. The consensus molecular subtype classification is increasingly being utilized in clinical trials to stratify patients and is expected to play a growing role in clinical practice for prognosis and therapy selection, particularly in metastatic disease. In conclusion, the molecular classification of colon cancer represents a revolution in oncology. It has moved the field from generic chemotherapy to a sophisticated, personalized medicine paradigm, where treatments are tailored to the unique genetic and epigenetic makeup of each patient's tumor. This progress offers hope for improved patient outcomes and more effective, individualized care. Thank you for joining us in this exploration of how molecular insights are shaping the future of colon cancer treatment. We hope you found this episode enlightening and encourage you to stay tuned for more on the Everything Surgery podcast. Dissect the extraordinary.